I feel really good about this industry being in their hands. None of us are unclear on the fact that our industry is in significant change, going through a significant change. But as the young people who have worked so hard to carve out a career for themselves in this field go forward, it's of great comfort to me when I look at them and realize what good hands this industry is in. Brad has a passion for looking at the entire family system. That passion became clear to me very early on in working with him, with clients in Renaissance. There was always something very special about the work that he did. When it came time to look for a successor for Sid, Brad was always my first choice. It's with enormous pleasure that I present to you the Executive Director of Caron Renaissance, which I still think is one of the best jobs, if not the best job, in this industry. Brad Sorte. Thank you.
Thank you. Good afternoon. Can everybody hear me? Great. Thanks, Bill, for a wonderful introduction and also a wonderful introduction to a little bit of the history of the organization that for the past now 3 months I have been very gratefully and very humbly been entrusted with the responsibility of leading. A couple of things before we get started today. When I was asked to take the honor of giving this talk this afternoon, I really had given it a lot of thought. And I really want to kind of drill down to even the basic meaning of what it means to give a keynote speech. I've spoken a lot about different interventions, modalities, ways of treating families, ways of working with high net worth clients, 2 areas where I've got a lot of passion and expertise. But looking at what my goal and hope was for today, I looked at the definition of a keynote speech, and it's a conversation or a talk that highlights a meaningful message, an underlying message, or an underlying theme for a greater context. And so I really wanted to look at this through a different lens than I had looked at other talks that I have given. Because I think that we stand at a very interesting time in our industry. The field of behavioral health, and before that, the field of addiction treatment, has a very colorful past, an interesting past, a past that has a lot of foundational pieces that we can build upon, but also a lot of challenges that I think that we, as professionals, as the beacon that people turn to in oftentimes their darkest hour, have a tremendous responsibility to lead them to the light, so to speak. So I really wanted to kind of tie together a couple of themes that, to me, are incredibly important. So there we go. So I'm not going to go through my biography, but there's one part of it that I did want to highlight because I think it's very important. In my previous work, before going to graduate school and through graduate school, my first master's was in social work. One of the things that became apparent to me in a lot of the contexts where I had interned, positions that I held where I was being paid, was there seemed to be this missing piece in healthcare in general, but in particular in our industry, of organizations that had sound, strong clinical leadership that also had a good foundation and understanding of how to run a business. And so my experience kind of spanned the globe, from the clinical manager, the clinical executive who had made their way up the ranks and by virtue of being the seniorest member of a team, had found themselves in a position of leadership. And they were fabulous clinicians. They were great group therapists. They were insightful as anyone that I'd ever met. But they didn't have that peace, that knack, that understanding, that vision, and that strategic mindset to be able to successfully run a business. And as a result of that, the organization suffered and patient care suffered. The flip side was the business owner who didn't have any clinical experience, who could run a P&L, who could manage a budget, accounting, and even be strategic from a business sense, but didn't have that clinical nuance to know when to give up the little battle to win the overall war. When it mattered to do something a little bit differently, to think a little bit outside of the box, because a small change in the system right here can affect a much greater outcome as a whole. And it became clear to me in the very last class, in the very last semester of my MSW, when I took a class on administration, which was supposed to be the foundational class so that if we did go into administration, we'd be ready to go. And I said, I have no clue how to run a business. I do not feel competent leaving this institution this May and being entrusted with running a business and being able to do that with the level of knowledge, experience, to be able to make that successful. So I promptly enrolled in an MBA program. Started work at Renaissance on May 5th, enrolled in the MBA program on May 9th, and I was kind of off to the races from there. But what my vision really was with it, and I'll kind of tie this all back around in the end, was there's such a need in this industry for the gifted clinicians that many of us are, to also find the time, devote the resources and energy to get that other piece of the picture. It doesn't have to be a whole full-blown piece of their education, but just something, and investing just a little bit. And I think that what you might see as we kind of talk about some of these things over the course of this afternoon, the mindset that it takes to be a gifted and intuitive clinician is not mutually exclusive to the mindset that it takes to be a good strategic thinker from a business perspective. And in fact, I think the two actually marry one another quite nicely and are very complementary. So, kind of the objectives that I wanted to cover today, and this probably isn't the most revealing list of objectives, but it wasn't intended to be. A little bit of a history about, where have we come from as an industry? It's important to understand where we've come from, and it's important to recognize, pay homage, and give credit to the things that we've gained through that process, because it creates the building blocks for what we need to do going forward. But then the big question becomes, where are we going from here? How do we get there? And how do we take what we've learned from these previous successes? How do we build on the foundation that was laid before us by generations of professionals to ensure that we are creating better outcomes for the people that we work with? So, just a brief history here. Most of us probably know this. Going back to 1935, the beginning of the 12 steps, from one of the first opportunities in the modern era where people began to have a place and a forum where people struggling with alcohol addiction could go, could get help, could find support, could have fellowship, and could have a community. From there, we started to see progress in other areas. We started to see the development of the Minnesota model in the mid-century. The disease definition came around the same time. And then in the 1960s, as a different direction, we saw harm reduction. The advent of the methadone clinic as an ability to recognize that, well, maybe not abstinence is the method for everybody to be successful, but perhaps if we can provide somebody an alternative so that their use, if they're going to continue to do so, can have more of a utilitarian outcome in causing less harm to the people around them. Then we have the 90s of the managed care era, with the emphasis on cost reduction. And then finally, as we come up to the present day, we have our present kind of era that we're in now, which recognizes the value of longer-term treatment, more of the beginnings of kind of our behavioral health care focus, taking a more multi-systemic approach to looking at this. What role does the brain have? What role does the family have? What role does the social context that somebody comes from have on the overall health of an individual? How can we start to integrate technology, whether that's pharmacological technology, whether that's neuroscience, and then some of the other pieces of technology I'll talk about a little bit later. And probably as a reaction to the managed care era, and probably one of the more important pieces that evolved from that, was a return to an emphasis on longer-term care. And to a large degree, that kind of brings us up to the past several years. So, if we were to look at this, and we were to look at kind of the arc of this and the history that we have had as an industry, one would think that, 85, 95 years of history here, we should probably be doing pretty well with our outcomes. I'm not okay with these numbers. And this is just a small part of the picture. We're talking about, from alcohol, 88,000 deaths directly related to alcohol abuse every single year. The third leading cause of preventable death. 43,000 deaths per year due to overdoses. And that in the past year, more people aged 12 and older have used drugs than in the previous 10 years. And this is just the tip of the iceberg. I mean, how can we possibly truly quantify the social costs that are incurred from all of the other consequences that occur around us all the time? Divorces, car accidents, lost time from work, lost time from school, emotional catastrophes that break families apart. I think it's funny no, it's not funny, but I think that it paints the absurdity of how bad this problem is when you think about the fact that I challenge any single person in this room or outside of this room to find me somebody whose life hasn't been touched by this in some capacity, whether personally in their own life or somebody who's one degree away from them. So it emphasizes just how significant a problem this is and just how much farther we have to come. So I put this up here for comparison, and I understand it's a facile analogy. It's not meant to be apples to apples. I picked it for two reasons. One, the peak of the polio epidemic in the United States was in 1953, which was reasonably close to, the early phases of what we were talking about in terms of addiction treatment. And the number of people affected in that year were, in the vicinity of the number of deaths that we have either from alcohol or drugs at this time. But we have 0 cases today. And I recognize that to compare polio to something as complex as addiction is not intended to be a direct comparison. But the reason I put that there is to be aspirational. Because as cunning and baffling as solving this problem is to us today, was that problem to people 75, 85 years ago. The mystery of invisible bacteria, minuscule viruses, and how these things could affect human health, and how we could possibly find a way around them, and how we could possibly ever find a way to not have people suffer from it, was as much a mystery to somebody at one point as how we help the thousands and millions of people struggling with addiction and alcoholism and the families who are impacted that every single day. So I want that to be our bar. I want us to be keeping in mind that it would be nice to strive for a 0 instead of an 88,000, for a 0 instead of a 43,000, for the number of Americans who had used drugs in the previous year who are over the age of 12 to be going down precipitously. And that's one of the things that I really was hoping to convey as a theme that I would like to highlight for our conversation this afternoon and for this conference and for all of us as leaders in this field, to strive for that. So, a little story about where that epiphany came from. Does anybody know what that is? Would you say a robotic operating machine? Yes, it's the Da Vinci robot. The Da Vinci robot is exactly that. It is a robotic operating machine. The personal significance of the Da Vinci robot was this machine and its connection to somebody, a friend of mine who I'm very close to, was part of what kind of jogged my thinking into, maybe we need to start looking at things a little bit differently. So it was back in May, a very good friend of mine, I got a call from him. Almost serendipitously, he had found out that he had a heart defect. He had a mitral valve prolapse and a mitral valve regurgitation. He promptly proceeded to tell me that it's actually not that big a deal and that it's just going to be routine open heart surgery. I could tell through his tone and the way that he was talking that he was trying to convince himself of that, but at the same time, it really kind of rocked me. This is the first time I've ever had any experience with something like this. This was a guy who was my roommate for 5 years. By far, one of my best friends. He had moved away, but to hear that he had had some health consequence that was going to require this frightening idea of open heart surgery, as the good little student who decided to enroll back in graduate school after finishing grad school, I went right back to doing what I do best, which is to research. And I wanted to learn everything about what this meant for my friend. And what I found was this was a key component of what was going to fix his heart. A robotic machine controlled by surgeons from computer terminals that could achieve things that theoretically a human hand could not, in terms of the flexibility of being able to turn one way or the other, not having the same tremors that a human hand would have. And again, I did lots of research. The machine's not without its imperfections. But it really made me start thinking about something. Where's our version of this? If our field has been around for nearly 100 years, where's our exponential or logarithmic uptick in the level of efficacy and the level of success that we can have in treating patients? I imagine that it's probably not going to look like that, but why can't we have something like that? Why can't we have some device that, to people not that long ago would seem like something out of a science fiction movie available at our disposal? So I started thinking, all right, so I kind of know what treatment looked like 90 years ago. I know what treatment looks like today. Now I know what heart surgery looked like today. And I said, I wonder, for comparison, what were the tools of heart surgery like 100 years ago? Ugh. It looked like that. And it just really emphasized even more to me, there's a disconnect here. What we used 100 years ago for heart surgery are reminiscent of the Bronze Age. And what we use today is reminiscent of something from Skynet and Terminator. So it really got me thinking that maybe we need to really start to think long and hard about how are we going to achieve those same types of success in our field. So, emerging trends and interventions. Well, really, what do I want to talk about here? I want to talk about a few things that I think really present as some of the greatest opportunities for us as clinicians, as executives, as professionals, interventionists, doctors, whomever, wherever your discipline may be, that I think can help get us there. And some of the things that I think we may actually be standing right on the surface of. The first bullet point there is one of the most important pieces to all of this. And it's really taking a systemic approach to everything that we do. Everything from looking at each person as a system, as a multi-systemic organism, to their family system, to their social system, to the systems around them, to how we look at ourselves organizationally as cultures. Whether we work in a treatment center, whether we work as a collaborative alliance of professionals, how are we seeing that the relationship and the interplay between each and every one of us has a profound impact on outcomes and working together? And I'll spend some more time elaborating on that. We have a huge piece of what is so essential to our patients and their families and their wellness and their well-being that has historically been not included or neglected in the treatment of our clients. And it's the primary care doctor, the gatekeeper for most people's engagement with the healthcare system, the person who is usually the first point of contact for an individual struggling with a health issue. But we have so many challenges with that. We have a primary care industry that is overworked. We have a shortage of primary care doctors. We have a problem where when it comes to drugs of abuse and dependence, it takes 2 seconds to say yes and a half an hour to say no. We have a lack of education. Maybe we even have a lack of outreach. How are we connecting with primary care? How are we seeing them as a valuable resource, not only for our patients and clients on the front end, but also on the back end returning home? And how can we strengthen those relationships and strengthen those bonds and help to see those individuals as collaborative partners? Now, I'm not saying that this isn't done, but I'm saying that as a point of emphasis and as a place where energy would be well spent, is how do we start to see this important piece of the system as something that we need to be focusing our time and our energy on? Family. Bill mentioned it in his introduction for me. My first introduction to this field as a clinician was working with families. And I didn't know it at the time, but it became a foundation for the way that I think about all aspects of care. Because it's only partially significant that the family system happens to be related to the patient in treatment. It's more about the fact that it is a powerful system where changes in one part of that system affect changes in the whole. And our patients and clients and their families exist in these multiple systems. And so when we see the power of being able to change one part of the system to achieve better outcomes for the whole, we can take that same knowledge, we can take that same vision, and we can apply it elsewhere to other systems. Now, I think the other part that's essential about looking at that emphasis on family systems as a key component of care going forward is actually something that we have seen as a real movement in our field. The move away from simply educating families on addiction, on enabling, and actually recognizing that the challenge for families to actually change their behavior and their reactions to their loved one is almost as great an undertaking as it is for the identified patient to change their reactions and responses, oftentimes leading to them to act out, engage in self-destructive behaviors. And so this idea that we can no longer be successful simply giving some information to somebody who is a family member and sending them on their way, but actually doubling down and identifying that the process of recovery for a family member truly is a parallel process. Maybe not in pace, but certainly in course and scope, and many times magnitude. So we've seen that part start to shift. I also think that family, to me, is a relatively loosely defined construct. So we have family of origin, we have the people that someone grew up with, their parents, their siblings, their grandparents, their children, their spouse, whatever it may be. But why not expand that definition? Why wouldn't somebody's family, depending on what their circumstances look like, include their employer, include their friends, include their neighbor, including some person that they happen to cohabitate with? And really recognizing that, once again, that system is impacted by the behaviors of the individual. And conversely, changes in the behavior of that system can affect changes in the greater whole as well as the identified patient. If we're to expand the systems even further, now we see the importance of organizational systems. Somebody comes into treatment at point A, and they leave treatment at point B. But they had a whole life prior to coming into that program. And hopefully, they have a nice, long, healthy life after they leave. They've engaged with many other systems, many other organizations, many other key stakeholders in that individual's life on both sides of the treatment episode. So how do we, as professionals, as guides, as people who are entrusted to help guide people towards a healthier way of living, recognize our need to be collaborative? How do we recognize that one of the best ways for us to help the people that we're trying to help is to understand what help they had received before, what help they are going to need later, and be collaborative partners in the process of connecting with those people to ensure that not only there's continuity there, but that there is also a drive towards the same mutual win-win of helping one another help people better. The last piece of this kind of shrinks back down to the organization level. We're helping people, especially when they're in a treatment context, break free from dysfunctional dynamics, uncover their core pathologies, remove barriers to sobriety, to a healthy way of sober living. But how can we do that if we're an alcoholic family system ourselves? And I think that that's such an important piece of all of this, is that how do we emphasize the significance of a healthy organizational culture as a key component to being able to help people the way that we need to help them? How do we model that behavior? How do we take care of ourselves? How do we support one another? Because it has a trickle-down effect. They may not be conscious of it, they may not say something about it, but they pick up on it. We don't go the extra mile when we're burnt out. It's hard for us to push a little bit harder when we're exhausted or we're dealing with problems within our own culture. So I think that to me is one of the huge pieces of emphasis that for all of us is such an important component. The more we're aware and conscious of what's going on under our own roof and what we need to do to improve those processes, the better we're going to be able to help the people that we're trying to help. And I think that, there's been too much of or there hasn't been enough of an emphasis on that. We work in a field, those of you who work in an inpatient setting, we work in a field where it's a 24-hour job, where there's always going to have to be somebody there. Crises happen at any hour, and they tend to happen at the most inconvenient hours on the most inconvenient days. I think that I can probably tally up how many times something catastrophic happened right in the middle of a Monday versus when it happens on a Friday evening or a Sunday evening. And we have to be so on guard for that. But at the same time, we can't allow the significance and the weight of that to take the place of the fact that there has to be that emphasis on our culture, supporting one another, and being healthy at home. Technology. We have a tremendous growth in the type of technology that we now have available to us. And this is going to kind of tie into another place of passion for me that kind of brings the two worlds of clinical care and business together. But if you look at what is now available to us as people, not even as in the context of our field. We can do so many different things that were not possible in only the recent past. We have the ability to bring together neuroscience and medicine. We have the ability to integrate pharmacological interventions to improve people's outcomes, to help support them through abstinence, and even the emerging science of being able to genetically determine somebody's sensitivity and metabolism of different psychotropics. So, right at the precipice of being able to take some of the guesswork out of which psychotropic is going to be the best fit for this person. And if we think back to how negative some people's reactions to certain medications can be and how that can be prohibitive to them wanting to ever take medication again, to get it right the first time can be a huge win. To get it right within a week of somebody coming into treatment so that by the time they leave treatment, hopefully 90-plus days later, they've had a chance to reach full effect of that medication as opposed to having to switch 3 times. It's a huge benefit that wasn't available not that long ago. The other part that I think is incredibly exciting, and this is where I think we are due for a paradigm shift, is the power and significance of what we can do as a result of mobile computing, mobile devices, teleconferencing, telecommunication, and all of the exciting things that are going to be coming down the pike as a result of that. I've seen, even just taking the example of some of the things that I had listed up there. We now have the ability for somebody leaving treatment to take with them a cellular breathalyzer that is a pocket case monitor that allows them to have accountability. It allows a treatment provider to be able to keep an eye on whether they're drinking or not drinking. It builds in a connection to a treatment program for them, when in the past this would require somebody having to uproot their life and go somewhere. Even the ability to connect with people at a distance on a face-to-face basis. No longer do people need to drive to connect with their clinician. I'm not saying that necessarily telemedicine or video conferencing is a substitute for everything, but it's certainly a long distance from just being able to pick up the phone. And in particular, I like that because of how many people who have these issues, who live in areas where it's very difficult to find help. So it extends care to those even who are outside of metropolitan areas. So, one thing that I think all of this technology really presents to us is the opportunity for some drastic changes in what we do and how we do things. I have kind of another little story here. So we all like Seinfeld. So this was years ago in my management of information systems class. I had a great professor that I really, really, really loved. And what we were talking about is disruptive innovation. We were talking about how so many things that we kind of accept to just be universal truths, things that we're always going to have, things we're always going to deal with, can very suddenly become irrelevant. And so the example that he gave to illustrate that was Seinfeld. Pretty generalized example. Everybody likes Seinfeld. And I actually, retelling the story, found out that it wasn't his. I would give him credit for it, but apparently it came from a conversation with Charlie Rose and Larry David. But what it was talking about was that the vast majority of the conflict that led to the comedy in Seinfeld episodes would have been impossible today, simply because of the advent of the mobile device. Having a cellular phone, having the ability to look something up on Google would have brought most of the conflict that took 30 minutes to resolve and was the source of all the humor, wouldn't have happened. So something that we didn't have, that we all lived without, that man lived without for tens and tens of thousands of years, we fought wars, we ran businesses, You know, we invented the heart transplant. We did all sorts of crazy, great, wonderful things without a cell phone, and now most of us probably couldn't leave a room without it. And so it was that illustration that I think really got me thinking about, well, what's going to happen with all of these new technologies, with all of these new tools that we have? When is the tipping point going to come where we can start to do things and reassess how we do things through a very different lens? And I think that we are getting very close to that point. You know, the definition of disruptive technology, it's very simple. When a new emerging technology replaces an existing one, unexpectedly. What will that look like for us? Will we be ready for that? And I think that the challenge for all of us is to be very conscious of that reality at some point coming. You know, Bill and I have talked about this, you know, several times. You know, there's hundreds of residential programs around the country these days, probably thousands now. I couldn't even begin to keep track of them. But I wouldn't be surprised if at some point in the not-so-distant future, we didn't have nearly as many as we do now. That we may be able to start to address some of the issues that have for so long riddled us, befuddled us, confused us, and baffled us in ways that are far more effective using different modalities. We go back to that slide in the beginning and we look at the numbers. There certainly is some pretty drastic room for improvement. So it's not that we've got the key, we figured it out, we know exactly what we're doing. I think we're all working together, we're all working very hard, we're all very passionate about what we're doing, but I certainly hope that when we see the number of people still suffering, that we all look at that and say, we're not doing, or we haven't yet done enough. That we have a long ways to go until we are where we want to be. So, the next piece of this, and this is another part of this whole process of how we look at things and how we look at our patients, how we look at the people that we care for, that I feel very passionately about. And I like to refer to it as cohort cultural competence. You know, since we've had the benefit of evolving our field over the past 100 years, and we've been able to see multiple generations come of age, struggle with addictions, struggle with mental health issues, struggle with a combination of the two, we now have a very useful set of data to realize that different generations really struggle with this differently. That different generations really respond to treatment and modalities differently. You know, and so to highlight just a couple of these, because I think that they really paint a very helpful picture as to the nuance of that, we have the collegiate population, a very unique group of individuals in a very unique period of their life that oftentimes, as a rite of passage, is very much characterized by drug and alcohol use and abuse. At least historically thought of as a rite of passage, but those of us who are working with that population have seen some of the pretty frightening and long-lasting consequences of the choices that that population makes. So, as opposed to simply just treating the collegiate cohort as your average young adult, evolving ways to begin to start to address the unique challenges of individuals trying to get into recovery and trying to stay in recovery while also finishing their academic endeavors. And there's a couple of points there that I always felt were very important to highlight. Someone getting into recovery and getting a job, $10 an hour, you can get 20 $10 an hour jobs in your life and you can lose all of them and no one's ever really going to care. But how many times can you go back to school and fail out or get kicked out before all of a sudden your options get very limited? Usually everybody gets one strike. Once you swing and miss a second time, things start to look a little bit different. So there's a real need to acknowledge that for a population at a reasonably young point in their life. So there's a level of responsibility that the collegiate recovering individual has that might be different than the young adult who's just working, because they hold in their hand a very important responsibility. Well, it's their academic career, it's their academic future, it's their grades, their transcript. And so recognizing that that individual doesn't have the same margin for error as someone who is just working a job requires a level of sensitivity. In addition to that, colleges historically have not made for the most inviting environments for people who are trying to stay sober. Now, we've seen a great movement in this area over the past, I'd say 5 to 10 years, where now there is a sensitivity to developing collegiate recovery centers. Now there is a real drive, grassroots movement within universities to provide sober housing, to provide recovery resources for individuals coming back to school. A recognition on the part of the schools that from a retention perspective and from a 5-year or 4-year completion perspective, there's a lot of value in these individuals having those resources and the support to be able to do that. And, I think we can really build upon the successes and the backs of some of the innovators and the pioneers in our field who really led the charge with that. But it was great to see that about 4 years ago, I went to a collegiate recovery conference where you had a few programs that had really been established and really had robust programs, and many that were fledgling, to now see 4 years later the growth that has happened in those programs that just started a few years ago. That we really have seen and identified that this is a group of people that requires us to be sensitive to their needs so that they can be successful. Another large group of the population is our aging population. We have an aging population that we divide into two pieces. We have seniors and we have boomers. And as most folks who work with that population will tell you, they're not going to see eye to eye that they're slowly becoming one and the same. So we need to have a level of cultural competence to recognize that a large tide of the population is not only aging, it's also experiencing growth and addictive issues, complicated by the medical complications that come with those addictive issues, and simply the medical complications that come with age. So how do we make sure that we are providing adequate and robust resources that are meeting the needs of those individuals? How can we be sure that the interventions that we're applying are going to fit with how those individuals feel about themselves? Simply looking at the ideals of some of these different generations yields some very useful insights. So some of the things that I've learned along the way from most particularly from some of my colleagues like Dr. Barbara Krantz and Dr. Jamie Heisman, is that you have these two generations that have very different set of values. You have the World War II generation that was very much trusting of authority, that sees doctors and professionals as really being a source of wisdom. And then the baby boomer population, the Vietnam War generation, that distrusts authority, that doesn't want to be seniors, that want to all stay 40 is the new 60 or 60 is the new 40, whatever it might be. And so how can we make sure that we are treating both of these populations as they're all aging into a group where they're going to be having very similar issues in a way that's effective, in a way that doesn't alienate them, and in a way that gets them the help that they need? another group that actually isn't on here, but it's something that I do have a real passion and an interest in, is working with people of affluence. And, another kind of, anecdote to this whole thing was, we opened a program at Renaissance called Ocean Drive about 3.5 years ago that was designed to treat people of affluence. And it was built on the foundation, on a theory that people of wealth encounter a lot of barriers to getting good care. And I remember when I first even heard that, I kind of scoffed at it. I kind of said, what are you talking about? What problems do they have? They can go anywhere they want. They can do anything that they need to. And that was exactly the problem. That was exactly the barrier that population encounters. We have this issue that we tend to dehumanize or minimize people's problems because they have money. And just kind of taking a moment to do a thought experiment. Think about how much money is invested in things like TMZ, Perez Hilton, these websites, these TV shows that make millions of dollars off of the follies and the pain and the suffering of human beings that are no different than you and me. But for some reason, when we see, the video of the bully picking on the little kid in the schoolyard, we have empathy for that person. But again, speaking in a general sense, when we see Amanda Bynes or Lindsay Lohan acting crazy, we want to sit there and poke fun and laugh. We want to relish almost in that person's misery. We watch almost in this almost sadistic way of kind of seeing this person's demise. And it's so uncharacteristic for us, for who we are. So, when it was framed to me that way, it really started to kind of click that, hey, there is something to this. And then there was another layer of it that I was able to start to see. And it's the fact that you have this group of people that historically people were always looking to get something from. They had people who were dependent on them, they had people who were sycophants, yes men, people who were just out for their own ulterior motives to get their own personal gain. And they're surrounded by people who are reluctant to be honest with them. They're surrounded by people who they couldn't trust. And so then what I started to really realize is that these do set up particular barriers for this population. And I had the privilege of actually getting to work with them at one point in my history. And what I really realized was when I would tell one of them no, when I would set a boundary with one of them, it would be probably one of the first times that they had experienced a trusting relationship because they knew I wasn't afraid for them to walk out the door and say, fine. They knew that if I was going to say, no, you can't do that, and if that means we can't have a relationship, if that means you don't want to work with me, I can live with that. At least they knew where I stood. And so it really, really, really reinforced to me that being in that group could inherently be very isolating. And it also really helped me develop a sense of empathy for the fact that, you know what? Somebody suffering is still their suffering. Their pain is still their pain. Doesn't matter whether you have 5 houses or you live in a cardboard box. If you're suffering, if you're in pain, that's that person's individual experience. And it requires and deserves the same level of compassion and empathy as anyone else. So the last cohort that I feel very passionate about and I have a great interest in is this one. Because I think this one is what's going to be the catalyst that connects us back to the technological innovation and the disruption that I believe we will inevitably experience in our industry. So you have a population of individuals born from around 1982 to 2000. There's 80 million of them today. the first generation to grow up on the computer. This is a generation that, they're the generation that made writing cursive go extinct. I mean, a form of writing that was evolved because of a quicker way to put things down on paper that became a dinosaur as a result of the advent of the computer. A very narcissistic generation. That statistic there, when I was kind of doing my research for this, was very striking to me, that there has been a significant increase in the levels of narcissism in college students between the 1980s and the late 2000s. And I can probably imagine that for all of you that work with that population, that's supported by anecdotal evidence as well. So it's an instant gratification generation. It's a generation that has grown up developing intimacy in ways that people born before 1980, 1975 probably don't quite understand. They've had access to things that most people would not have been able to access before. The proliferation of pornography. The amount of wealth of information on the internet about substances, where to get them, how to make them. That's if you live in South Florida, you can't keep up with the evolution of the research chemicals and the synthetic drugs that evolve faster than the laws can to prevent them. It almost makes you think for a second, well, what happened to, just good old-fashioned kids smoking pot and doing coke and all that stuff? Now they're doing flocka and spice and K2 and all sorts of other things that will continue to evolve. So there's a huge shift there in what's available, not just in a physical sense, but in an information sense. And their savviness as to how to access that gives them a leg up on people who don't understand the technology as well. One of the most interesting statistics that I found was that the one about their wealth. So for years and years and years, I kept hearing, and I know that they kept talking about this in articles, that the children of the baby boomers were going to be worse off than their parents. They're not going to be as financially successful. They're not going to have the same successes. They've grown up through the dot-com bust, the housing bust, all these recessions. Yet quietly, almost a quarter of the millionaires in this country are 35 years old or younger. So that means that a quarter, the oldest of that cohort, that's 35 years old today, has about 15 years left to reach their peak earnings potential. And already they're nearly a quarter of the millionaires in our country today. So as this generation continues to age and to grow into their own maturity, what are going to be their expectations for treatment? Are they going to come to treatment for 90 days or 120 days? It's a good question, because I think it's a question that we have to be asking ourselves. This is a generation that grew up with texting and with FaceTime and with Periscope and every other iteration of social media. They're a generation that is going to want to see outcomes. They're going to want to see data. And they're going to ask the questions as to, why do I have to uproot my life? Why do I have to immerse myself in something for half a year or a quarter of a year to get the same effect? Because everything else in their life has been served through the lens of instant gratification. So we have an intersection here of two things, potentially. Again, this is all very much theoretical, but my intention today was not to be prescient. My intention today was simply just to start to talk about some things that I think we all need to at least be considering and thinking, which is, how will the acceleration of the technology that we now have available to us to aid people in their recovery, a generation who, by their nature, embraces technology, that is born of technology. And how are those two going to come together? What's that going to mean? We're kind of just at the tip of this wave that's coming, where this group is going to be the future leaders of industry, the future leaders of the world, coming into positions of power. And I think it really kind of opens up an interesting conversation as to how is that going to change the way that we do things. And I think that if we even just think back to some of the things that we're now able to do, and just walking through the hallways and shaking hands and talking to people at a conference like this, you can already see that what only a couple years ago were niche devices and niche technologies that were either expensive or highly sophisticated or inaccessible or had a very narrow scope, have started to expand, have started to have more user-friendly interfaces and start to be more generalizable. And if we go back to that concept of disruptive innovation, that is at the crux of when that disruption happens. It's when that technology becomes available enough, accessible enough, and relevant enough to enough people that paradigm shifts. And I think that one of what is very important for all of us is to be aware and to be prepared for that. So, a couple of kind of thoughts to kind of bring things together. And I think that it's extraordinarily important for all of us to continue expanding our thought process in looking at all these issues systemically. All of the kind of the avenues that I conveyed and all the other ones that I didn't mention, but really recognizing that this issue that we're dealing with requires one that recognizes the interplay of all of the pieces in somebody's life, not just in the present, but in the past as well as moving into the future. I think we need to continue to be innovative. I think that we need to continue to challenge ourselves to not simply be satisfied with what we're doing, how we're doing it, but truly be driven by the idea that people are still dying, people are still suffering by the thousands. And that as long as those numbers continue to be as great in scope as they are, it's incumbent upon us, it's our responsibility to continue to think outside of the box, to be innovative and find new ways to help people. I think that the shift towards a behavioral health care focus from simply addiction treatment was so important to that. It ties in both of those 2 points. It takes a more systemic approach. It takes a more systemic way of thinking about things to do that. And it also opened the door for innovation. But at times, our field can be stubborn about embracing innovation, about being forward-thinking. And I think that needs to be a mandate that we all carry, which is recognizing that whatever comes down the pike, whatever role we take in pushing the bar upwards, we need to be willing to embrace change. We need to be willing to embrace change because on some level, the outcomes and the successes that we have had and that we can build upon, at least for me, aren't adequate because it still leaves too many people who aren't getting, aren't able to have the lives that they deserve. So, kind of coming back on one of the initial things that I was talking about, this is why it's a particular point of interest and passion for me that we as a field, as an industry, as a small part of healthcare, but a very important part of healthcare, rise to the challenge of taking on more strategic roles in how we run our organizations, how our organizations work with one another, how we support one another, and how we continue to think more strategically about moving into the future. So I wanted to leave some time for questions as well. If there was anything that anybody wanted me to circle back on or elaborate on, or if anybody thinks that I'm crazy, I'd be happy to hear that as well. So. Yes, sir.
Hello.
There we go.
In your opinion, what's the most important thing that Caron or organizations in the field need to do to focus on improving the recovery of addicts and alcoholics that leave treatment?
Absolutely. You know, I think that there's two things. And I think especially as we stand here right now, the two parts are to continue to grow our emphasis on how we treat family systems as a whole while someone is in treatment, and being creative and being open-minded about how we define that, and having the courage of kind of our convictions to recognize that at times that can be a laborious endeavor. You know, you go from treating one person to maybe treating 6 people, but that if you're able to address the dynamics and the other members of that system, that you create a healthier context for that person to go back to. And then beyond that, I think the emphasis needs to be on how are we staying connected to and nurturing individuals after they have left treatment. We have such great tools to be able to do that now, and it evolves as the days go by. Continuing care and aftercare through case monitoring, through breathalyzing, through even more elaborate type programs that have people coordinating an individual's care. Because if we also think about it, and you know, if somebody feels like they're still connected to a program, a professional who helped them get on the right track, and they know that they have a phone call, or they've got a message on an app, or they have a breathalyzer they have to blow into. Even that small little connection back to that treatment program makes them feel that much more inclined to pick up the phone and ask for help when it comes. And the longer we can stretch that, the better. Yes?
I mean, I've been in the field for 28 years, clean and sober 37 years, and I'm a certified addiction professional, and I have a treatment program for 15 years. I found that the 12-step recovery piece is a very, very important piece. For addicts and alcoholics, once they leave treatment, to have a network of other sober men and women that they can relate to. And I find that that is probably the most important in the first year than anything, that it keeps them dry, keeps them clean. All the other stuff is extremely important in conjunction with that. So, and I see a lot of programs, I don't hear them mentioning that, because let me just say this, every addict and alcoholic that maintains recovery, sobriety within the first year, and I'm going to tell you that 90% of them are in a 12-step program with a sponsor, working the steps and developing a sober network of individuals. The ones that don't do that, they relapse, and when you call them up for outcomes, oh, I'm doing fine. You don't know they're doing fine. So I think that's a big piece that needs to be addressed for all the treatment programs. It's something that seems to be assumed if we give them great therapy, and talk to them on the phones and tell them to come to aftercare, that's going to help them stay sober. And without a network of sober men and women, it's all nil, in my opinion. It's more than my opinion; it's my experience.
No, and I think that you raise an important point, and I would even go one step further, which is to say that component and that connection with fellowship shouldn't be something that happens or begins as they leave treatment. It really needs to be something that happens in treatment. You know, and so kind of, again, speaking from the context of my own practice and where I've worked for my whole career, the idea of a Florida model where we're treating people in one clinical setting and they're living residentially elsewhere, the expectation is that for those 90 days to 180 days that they're in treatment, most often for that clientele relocating, that is folded into the milieu. so that they are not leaving on day 90 or day 180 with a list of names that they need to be getting connected with, but by the time they leave treatment, they've already habituated to using and being connected with those sober resources. To go even further, and I think that one thing that we have found has been tremendously valuable in that, and I guess we're lucky because we've had the luxury of a lot of our folks relocate to the local area, is connecting new folks coming through our doors with our alumni on day one. Give people somebody that they can connect with. And we found that that was not only so successful with the patients coming through the door, but with the families of those patients who are back at home. Connecting those family members who are coming through the door saying, why do I have to go to FA meetings? Why do I have to go to Al-Anon meetings? With a family member that says, hey, you know what? Yeah, Brad's a pain in the neck because he won't stop nagging you about that. But I got to say, at the end of the day, he might know what he's talking about. This is what I learned, and this is what I did. And it kind of connects the dot for that individual that, okay, it's not just somebody telling me what to do. I can see from someone else's experience why this adds value for me. Does that make sense?
Hi, Brad. I think a part of the connection, too, is with everybody that's in this room. So we need to be connected. You know, we need to be constantly collaborating so that the clients then can be connected. My name is Barbara Colon. I'm the clinical nurse lead at Bon Secours Community Hospital. I'm very excited to be at this conference, and I'd like to share just a couple of things that we have embraced in Orange County, New York. We actually collaborate on a regular basis, on a monthly basis, with all the outpatient, inpatient providers of behavioral health, so mental health as well as substance and chemical dependency. And we get together and we basically discuss what happens in our offices, our institutions, and we bring it to the table. It can be a scary conversation at times, but we try to be as much innovative and creative leaders coming on board to really embrace the changes and transitions in healthcare. So we need to jump on board and really participate in connecting with each other so that our clients do get the best care and they are constantly connected in the community so that the follow-through is on point.
Absolutely. Thank you. Anyone else?
A couple of questions.
Sure.
One, the big purchase foundations recently, the other one of CRC by larger groups. Trends that you're seeing going with that, both are saying that Obamacare is going to open some more funding.
Is that when somebody calls us and we're not the right fit for them, do we help connect them with the program that is? So many people get one crack. They get one chance. They get one opportunity to do this, and if it's not the right fit and it doesn't meet their needs, we can really lose an opportunity to help somebody. So, you know, whether we're consolidating our industry and finding ways to work together, or we're continuing to, you know, be relatively fragmented, the challenge I think that all of us need to take is to ensure that whenever somebody is reaching out for us for help, that we take it as our duty, if we're not the right place to help them, that we can help connect them with the right place that will be able to do that. The second thing that you raise, I think, is a huge piece, and it's the proliferation of these new compulsions related to technology. One, I think for most people who are practitioners working in an inpatient setting, we can all personally relate to it, simply because of the reactions that we all have to the bing, bing, bing of our emails. We've become so addicted to our mobile devices and the stimuli that we get from, you know, is this bad news? Oh no, why am I getting an email on a Saturday? Uh-oh, why is so-and-so calling me? that it's something that has already even kind of infected our own organizational cultures. And I think that one of the challenges that is going to be a huge one for us is not understanding what the next generation is actually capable of doing, engaging with these devices. And I think that it's a huge challenge that you see parents struggling with. It's a challenge that we struggle with our patients in treatment when they've moved to the point that they're looking for work. So we have, for example, we've got computers that the patients use when they're on the job search component of their program. Now they're blocked so they can't go on Facebook and all that stuff, but they find ways to use proxy servers and get around it. And so that's a real challenge for us as professionals, is that if we're at the point that we're at, we got here because we've worked, we went to school, and unfortunately we're not 14 or 15 years old anymore. And as a result of that, we're disadvantaged in being as enculturated into those technologies as our younger clients are. So I think that from that perspective, I think it's a huge piece of that is staying very current and really recognizing that the connection that the young adults have with their electronic devices is something that is going to play a huge role. And really recognize that helping them step away from that is going to create the same levels of discomfort of detoxifying from it as an alcoholic or an addict would being away from their substances. But I think the other side of it too, and kind of connecting the two dots here, it creates an interesting conundrum, is that that's the way they've socialized. That has become the way that they socialize. So even though we have concerns about the instant gratification nature of it, the almost avoidant way of it, and really the ability to expose oneself, it is part of the way that they have learned to communicate. So how do we help them learn how to navigate that in a healthy way? I think that's going to be a big challenge, and it's only going to be growing. Anyone else? Okay, well, thank you, everyone. I appreciate your time.